Good afternoon. My name is Dr. Clemens Nzuka. Today I'm just rounding up the headaches that I've been discussing. And I think I've discussed them so extensively. I looked at how to abort a headache, and at the same time, I looked at how to prevent a headache, prophylactic therapy. But now there's something at the plan for today. Like I say, it's a roundup. I want to say something about a headache in pregnancy. How do we manage that? What do we do exactly? Normally, with this population group that is pregnant patients, most of them, they don't want anything that will hurt the fetus or hurt the developing baby. That's very good. That's very good. But sometimes the headache is hacking, and then something has got to be done. What we do, we give acetaminophen and aspirin. If this doesn't work, then we go over to codeine. You can use that one judiciously. Codeine. And we can go on to use tricyclic antidepressants. Or we can use periactin. So basically, that's what we can use. But we respect the opinion of the mother. Most mothers are careful about what is transmitted to the baby. And that's very good. That's very good. If we can do without medication, that's first class. And then we go on to talk a little bit about a tension headache. Tension headache, there are two types that we look at. We look at an episodic headache, and then we look at a chronic headache. Those are the two categories when we are dealing with it. First of all, how is a tension headache different from a cluster headache, for instance? From the different types of headaches that we've been talking about, how is it different? This one, its location, number one, tells us that this is a cluster headache. It can be frontal, it can be temporal, both temporal areas, regions. It can be occipital. So it forms a band around the head, And some people refer to it as a muscle contraction headache. And then the first thing that you want to know, how do we manage this? Primarily we use the NSAIDs, non-steroidal anti-inflammatories. And when we say non-steroidal inflammatories, we mean indomethacin, Indesit. We mean diclofenac, that's Voltaren. We mean Brufen. And those are the ones that we use to abort a tension headache. But then if these are not working that well, we go to the suppressive drugs. Tricyclic antidepressants are very good at this. Tricyclic antidepressants. Well, when you say tricyclic antidepressants, this needs to be explained very clearly, because you can mean amitriptyline, you can mean nortriptyline, you can mean imipramine, you can mean doxepin. Which one exactly helps with this type of a headache, a tension headache, or a muscle contraction headache? Which one exactly? It's a particular type of a suppressor, tricyclic antidepressant, the suppressive ones. It's a particular type. The one that is serotonergic. In other words, it increases the levels of serotonin. Serotonin, you remember, we said it is a happy chemical. It's a happy hormone. If the levels are up, the patient will be happy. If the levels are down or they're deficient, then the patient will be unhappy. That's for sure. So you have to. So a serotonergic tricyclic antidepressant is a suitable one. But which one out of these? Remember, we said there's amitriptyline. We said there's nortriptyline. We said there's imipramine. We said there's doxepin. Which one is serotonergic? Amitriptyline. So when you're using amitriptyline, you must know that you're using a tricyclic antidepressant, which is gonna elevate the levels of serotonin and a happy hormone, so to say. So the patient will be okay. So amitriptyline, we choose it because of that. It's serotonin. It's serotonergic. In other words, it increases the levels of serotonin. That's good. That's good to know. So it's different from nortriptyline, different from imipramine, different from doxepin. All right. So that's what we're doing when like I said, I'm rounding up all the headaches just to make sure that we have them in perspective. I want to say just a little bit about headaches which are generated after a spinal tap. In other words, after a lumbar puncture. Yes, after a lumbar puncture. Then you see these headaches. So what do you do with these headaches? Well, you'll have to go with your primary analgesic, and you have to make a decision as to whether am I gonna do another. Remember, what you need to check is the spinal CSF pressure. So if you take some, you decide if the pressure is high. How will you notice that the pressure is high? By doing another lumbar puncture. In the process of doing that, you'll be able to see that there's pressure here and all that. Then if you remove some of the CSF, then you'll find that the headache is actually at rest. And we don't run away from our tricyclic antidepressants because they're actually good. And as we know now, that amitriptyline is actually the best. Now, I would like to say something. Remember, I'm rounding up all the headaches. I would like to say something about a headache that comes about because of a tumor, a brain tumor that's there. So it's a space occupying lesion. And therefore, if it's a space occupying lesion, it's going to exert a lot of pressure on the CSF. So there's going to be an increase in the intracranial pressure because of this space-occupying lesion. In other words, this tumor. Man, it's good to talk about these just to find out, how do you know that this headache that I have, it is because of a developing spinal, well, a developing brain tumor. How do I know? Patient will wake up very early in the morning, 4 o'clock, 5 o'clock, 5, like early in the morning, with a headache. In other words, the headache will wake the patient up. So in the morning, when the patient will sleep peacefully, but in the morning it will start hacking, then your suspicions will be towards a brain tumor. And that will force you to, if you tell a doctor this as a patient, you say, hey man, I get my headaches in the morning, early in the morning. Every day I've got this headache. If you have that and you tell your doctor is going to make a decision. Hey man, let me find out. Is there anything growing in the brain? How do I find out? Brain CT scan. How do I find out? MRI. MRI is magnetic resonance imaging. Some kind of a sophisticated, radiological examination. But you ask for it, and that's all. You just ask for it to say, look, please do a brain CT scan just to find out if there's anything in the brain. If there's something in the brain, that's for sure. That patient, you're not going to start treating. I'm an OPT doctor. I'm not going to treat that patient. I'm going to hand the patient over to the neurologist. Remember, the neurologist said, my nightmare is a headache. Because I don't know what is the cause of this headache. I don't know at all. I don't know. Is it a brain city? Is it a brain tumor? If it's a brain tumor, have I done my brain CT scan? Have I done my MRI or something? So this is a shall I say, a nightmare of a neurologist. Let this nightmare be dealt with by a neurologist. Once you find that, if the results come back and they say the brain CT scan results say there's a tumor in the brain that is actually developing, that patient is not yours. Hand the patient over to the specialist, that is the neurologist, right? So it was an increase in the intracranial pressure which gave you an idea of what's happening. Look, if you do your lumbar puncture, man, that needle of yours is pushed back, that kind of thing. So you are in trouble. So you know that the pressure is high here. Yeah. Then that's what led you to do a brain CT scan and an MRI. But we have to answer this one question. Is that the only time that we get an increase in intracranial pressure? The answer is no. The answer is no. You can get an increase in intracranial pressure. In other words, you can do a lumbar puncture, thinking that yes, the patient is having a headache, but the patient, and then you do your lumbar puncture, and it's pushed back. I mean, your needle is pushed back. I mean, the temperature, the intracranial pressure is too much. The intracranial is high. So you say, oh, this is a brain, this is a brain tumor. No, not all the time. Not all the time. But to which situations do you find an increase in intracranial pressure when there's no malignancy, when there's no brain tumor? There's no brain tumor. You've done your brain CT scan. You've done your MRI. No, there's nothing growing in the brain. So what would you say this is? This is given a special name. It's called a pseudo tumor cerebri. It gives the impression that there's a tumor that's actually growing there when there's no tumor at all. What could be the problem? What increases the intracranial pressure? Because there's nothing pressing. I mean, there's no tumor that's actually pressing. It's not only the tumor that has to press. The accumulation of the fluid in the CSF can increase the intracranial pressure. But where does the fluid come from? Let me say something to you about. If you have you have your blood vessel that is adjacent to the CSF, that is cerebrospinal fluid. That blood vessel is in a region of high concentration of water as compared to the CSF. CSF is in a region of low concentration of water. So now there's migration of water from a region of high concentration to a region of low concentration to try and maintain equilibrium. When this happens, there's going to be an increase in the intracranial pressure without any malignancy. And this happens in several conditions. Hypoparathyroidism. This is what we notice. There's another hypoparathyroidism is when the calcium in the blood is deficient because of the parathyroid hormone. Low levels of parathyroid hormone is deficient. So now it becomes a region of high concentration of water, and so if it's adjacent to a CSF, which is a region of low concentration of water, so there'll be a migration to try and maintain a balance. There'll be a migration of water from a region of high concentration to a region of low concentration during a process known as diffusion, or in this case, it's osmosis. There's a special kind of a diffusion known as osmosis. It goes across a membrane, and then this is osmosis. This is what is happening. It is that difference between the two compartments, now the CSF compartment and the blood itself, the plasma itself, the blood, the actual blood, right? Whether you regard it as serum or you regard it as plasma, but the blood itself. So it's a region of high concentration of water, and the CSF is a region of low concentration of water. This happens in quite a number of conditions. For instance, there's a condition known as Addison's disease. Addison's disease is when the adrenal gland is unable to produce the hormones that it's supposed to produce, or it produces them, but produces them in small amounts. So there's a deficiency in some of the hormones which are supposed to be given out by the adrenal gland, like for instance the cortisol. Cortisol is responsible. Remember, cortisol is responsible for what is known. It breaks down glycogen, which is stored in the liver. It breaks it down to glucose. So it's called glycogenolysis. That process. So this is promoted by cortisol. But now there's no cortisol. Is too little. There are low levels of cortisol. So there's very little solute in the blood. In other words, there's very little glucose in the blood. So it becomes a region of low concentration of the glucose, but a high concentration of water. High concentration. So if it's a high concentration of water and it's adjacent to what? It's adjacent to CSF, which is a region of low concentration of water. So now there's this migration. That migration causes the pressure, causes an increase in the intracranial pressure. This is good to know. Go over it like that. Cortisol levels are low. There's something else. If there's Addison's disease, there's something else that is deficient. Aldosterone. Aldosterone is that hormone that is responsible for acquisition of sodium. In other words, sodium levels go up if the adrenaline is in adequate amounts. So it goes up. But think of adrenaline when it's in low levels. It means there will be very little sodium being attracted to the blood, to the blood. So if there's very little salt or sodium, you know, salt is sodium chloride, right? So salt, so it means now there's deficiency of the salt, but a high level of what? Of water. So water is going to migrate from a region of high concentration to a region of low concentration. Try and maintain equilibrium. This is good to know. So adrenal and the for cortisol, first of all, will do it. It will do if the low levels. Addison's disease now, yes, Addison's disease. Addison's disease we see it by cortisol being low. We see it by aldosterone being low. Aldosterone, when it's low, you know that you're not going to have much salt. So there's going to be low levels of salt in the blood. So there's going to be high levels of water. Therefore, if salt is not there, so water is going to be abundant. So if water is abundant, it will move from a region of high concentration to a region of low concentration. That's good to know. This is known as pseudo humor cerebri. Increased intracranial pressure without any space occupying lesion like a tumor. There's no tumor, there's no malignancy, but there's an increase in intracranial pressure. This is good to know because we always think whenever there's an increase in there's a tumor, But then we've done the test, that is the brain CT scan. The brain CT scan says no, there's no tumor. There's no tumor. All what is happening is just an accumulation of water that is coming from a region of high concentration to a region of low concentration. There's another condition. There's another condition that does this so perfectly. You know, in the blood, the proteins, they get precipitated, leaving a supernatant liquid. You know, the supernatant liquid. Supernatant liquid is now without the proteins. The proteins are precipitated. And so this supernatant liquid is actually a region of high concentration of water. This is good to know. It's a region of high concentration of water, and it is adjacent to what? To a region of low concentration of water, which is the CSF. So there's this migration again. This condition is given a special name. They call it what? Cryofibrino. You know, the fibrin has actually precipitated. Fibrinergia. Because the protein, and we're using fibrin as an example of that word, it is precipitated. So cryofibrinogia. And this is a cause because there'll be supernatant fluid. Supernatant fluid, which is a region of high concentration of water, but a region of low concentration of air, of the proteins, because the proteins are precipitated. So now there's this migration. This is good to know. So the condition in general, which generates this, you get it even with the vitamin. You know, vitamin A, hypervitaminosis A. Hypervitaminosis A, you also get this problem of a migration of water from a region of high concentration to a region of low concentration. You get this. There's something called, you know, endocarditis is formed by bacteria. Endocarditis. Bacteria, they actually, you know, target the valve. We know there are valves in the heart, the mitral valve, the aortic valve, you know, all those valves. We know that if there's bacteria there, the bacteria will eat away the valve itself and cause endocarditis. But now think of a situation when endocarditis is not formed by bacterial attack, by non-bacterial attack, non-bacterial attack, but you still get an endocarditis. That one is called merantic sinus thrombosis. Merantic sinus thrombosis. And that is one of the causes of an increased intracranial pressure. Increased intracranial pressure in the absence of malignancy. In other words, you've got this pseudo tumor cerebri, something that gives you the impression that there's a tumor, but when there's no tumor. So merantic sinus thrombosis. This is good to know. What do we do to try and help out the situation? I am an OPD doctor. I make no qualms about this. Once I find that, okay, I've done a lot. Number one, I know now that there's merantic sinus thrombosis. Hand over the patient to the neurologist. Hand over the patient to the specialist. Hand over the patient to the physicians. Let them deal with that. I'm not going, at an OPD level, I'm not going to deal with that. I'm definitely not going to deal with that. Right. So basically, that's what you would do. Before I end this presentation, because I won't be talking about headaches anymore, I just want to finish them all. Spinal tap, yes, we know something about that. With the spinal tap, it's just to make sure that we reduce the pressure in this. But there's postcoital cephalgia. Postcoital cephalgia. This is a condition where there's a hacking headache before or after orgasm. So sexual intercourse. And this is rare. This is something that, but what is important here when you're actually treating this? You have to classify your headache as your headache. Is it coming from is it migrainous? Is it coming from a migraine? Or is it coming from muscle contraction? If it comes from muscle contraction, then I'll use my NSAIDs. I don't have a problem. NSAIDs are what? Non-steroidal anti-inflammatory drugs. Those I can use other the Indoseed, the diclofenac is your Voltaren. Indoseed is your indomethacin, your brufen and your brufen. I can use those. But and that's when I think it's muscle contraction. That is when I think it's muscle contraction. But when I think it's a migraine, what are you going to do? If you think it's a migraine, beta blocker. You know that we've been talking about beta blockers. Beta blockers, metoprolol, for instance. Beta blocker. Use a beta blocker, man. And then, the beta blocker, we know that we have to try to choose a beta blocker that is cardioselective, that goes towards the heart, and it targets the beta 1 receptors in the heart, and to the exclusion of the beta 2 receptors. Who would love that it excludes the beta 2 receptors in the periphery, because those in the periphery, they can cause problems. I mean, a bronchospastic condition. If there's a bronchospastic condition like asthma, we don't like it. If there's a COPD, chronic obstructive pulmonary disease, we don't like it. Now we don't like a beta block. So this is where I my emphasis is always hand the patient over to the specialist, hand it over the patient to the physician, hand the patient over to the cardiologist. Let them decide on what type of beta blocker to use, that kind of thing. So the other problem with the post-coital cephalgia, which is this one that you get during sexual intercourse, you have to find out, is the headache not because of a subarachnoid hemorrhage? In other words, there's hemorrhage in the subarachnoid space in the brain. Because we often get this when there's an aneurysm that is actually leaking. If there's an aneurysm, that outpocketing of a blood vessel moving this way and it outpockets like that, that's called an aneurysm. That aneurysm, if it leaks into the subarachnoid space, that's a problem. That one has to be seen, has to be the problem of a neurologist, it has to be the problem of a physician. It can't be a problem in OPD. Right. This is what the very last thing that I would like to talk about is just a temporal arteritis. Temporal arteritis, the large blood vessels in the temporal area and the medium-sized blood when they are inflamed. And it's always good to think of these suppressive drugs like tricyclic antidepressants, like Peractin, or Peractin. If you use a tricyclic, or use a Peractin, or you use your NSAIDs. Initially, start with the analgesics, the normal analgesics, to make sure that you address the problem. That's what we need to be talking about. Thank you very much. Thank you very much. Thank you very much for listening to me. This was quite an intense and very presentation. Thank you very much.